Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Hello and welcome to all to today's webinar on lung transplant in India. Is it a reality? Brought to you by the Naruvi hospitals and the Hindu Wellness Series. A report published in the Lancet Global Health 2018 suggests a disproportionately higher burden of global chronic respiratory diseases in India at 32% and confirms the enhanced need for lung transplantation in India. However, fully accomplished lung transplantation centers are far and few, with most of them concentrated in Chennai, Hyderabad, Mumbai, Delhi, and NCR. The first successful lung transplantation was performed in India in 1996 in Chennai. Between then and now, 114 lung transplantation surgeries have been done so far, even as our doctors say that lung transplantation is the definitive treatment for progressive end-age lung disease patients and can help to improve the quality of life. But often apathy and lack of awareness makes the treatment option limited and also expensive. To discuss all these points in detail and the status of lung transplantation in India today and what more can be done, we have a distinguished panel of experts in pulmonology and lung transplant. The subject is vast, and I would like to introduce our guests one by one and invite them to give their presentations. And I would also request our audience who have joined us today morning for this important session, they are requested to drop in their questions as we progress once the Q&A box is opened. So for the benefit of better understanding, our panelists have divided the session under 4 broad and relevant topics. And I would like to first invite Dr. Vimy Verghese. Dr. Vimy Verghese is the consultant in lung transplant and also interventional pulmonologist at Naruvi Hospitals, Vellore. And he will talk to us today about the roadblocks of lung transplantation in India. So over to you, Dr. Verghese.
Thank you, ma'am. Good morning, everyone. I thank Hindu and Naruvi Hospital for giving this opportunity. And it's good to see everyone from different parts of India and across the globe join this seminar to create the awareness for the public and all the medical fraternities across India. So my topic is, it's a small topic. It's the roadblock of lung transplant in India. And myself, Dr. Vimy Verghese, who's working as a transplant pulmonologist in Naruvi Hospital. So when we come to this topic, everybody will have many thought blocks regarding transplant. Why is it important for India, and what are the usual thought blocks what we come across, and what we can learn or what we can improve from this. So when anybody thinks about transplant, usual thing what everybody sees is the ambulance coming fast, creating a green corridor, and the donor lung coming from different hospital. However, it's the other way around for the patients who is suffering with different lung disease. Usually everybody or each of the patient's question is, will my suffering with oxygen therapy has any endpoint, or how long it takes to get lungs? So these are the few things that everybody has in mind. So the usual questions that anybody has for them is, can it be done for my lung condition, or can I withstand the operation, or do I need to take a long medication, or whom I can ask for regarding the further questions. So we have just divided briefly about all these topics in short so that everybody can understand what we are dealing with. So as you know, India is it's a vast country. It's a second in the list for the largest country in terms of population, and we have almost 80% of the global diseases And many of the chronic respiratory diseases that it contributes to almost 6.5 percentage. So in short, we have what we're trying to say is India is a vast country, and there is many of them are suffering from many chronic respiratory disease, which makes it utmost important in this scenario about why many people do suffer from end-stage lung disease. So in 1999, it was the first lung transplant performed in the country by Dr. K.M. Cherian in Chennai. And our government has a strict rules for regulating the transplant. We have a national organization for transplant that is concentrated in Delhi, under which there are many regional organizations, and it is divided into specific state organization also. So what we're trying to understand is it's all strictly monitored, and it's strictly monitored in many aspects, so that other problems will not be happening. And we know that India being a large country, and there is n number of chronic respiratory disease. However, when we see as a whole, there are only few areas or hospitals that performs lung transplant. And many of the hospitals or the areas is concentrated in the southern part of India, like Chennai, Hyderabad, Mumbai, etc. And probably currently evolving into Delhi and NCR. So these are the usual problems because it's only happening in a few states in the country. And the other main problem is the disease organ donation. So India being a large country also, our organ donation rate is only just 0.52 per million population, as compared to Spain, which is as of now highest in the world, which has around 49.6 per million. So these are the usual problems that we have, even though we are a large country. And this we can see from this graph that India being the very low in the list as compared to USA and Spain. Probably one of the reason is in India, the person has to register to become an organ donor, and family has to consent to it after death. However, in Spain, it's something called an opt-out system, where a person is presumed to be a donor unless and otherwise specified. And after we came to know about this problem, there are many national health organizations like Mohan Foundation and many different foundations that creates awareness talks in many of the conferences and across the public, so that we can minimize the gap between the number of organs needed and the number of transplants happening in the country. Because this demand is on the rise because of increased prevalence of lifestyle diseases. And as everybody thinks, we have a different religious belief in our country, and mostly all religious beliefs support organ donation. So it is very vital about asking about the specific religious belief and what is their request in the pre-transplant counseling. Another thing is that we have the problem about tuberculosis, because India accounts for 1/4 of the global TB burden, and there is about 2.2 million cases out of the 9.6 million cases annually. So TB is a major problem, especially before the transplant when we screen this patient, and also in the post-transplant period. And as you know, India is a large country, so there are only few transplant centers. So it takes a long distance to reach the transplant center, so that if this is the problem, it creates more ischemia time, and getting an air ambulance is expensive. Because in small examples, if you're traveling from south to north of the country, it takes at least 3 hours by flight. So we had a good progress in transplantation pre-COVID, about 60 to 70 per year. However, after the COVID, we have come down. However, right now we are gone back to normal. Because of COVID, there was reduced transplant referrals and increased mortality for the patients on the day clinics, etc. This is the survival data regarding transplant. So this is from Dr. Robin Moss, which is a paper which is published in the international registry, which reports a 1 and 5 year survival of 85 and 59 percentage. However, when we come to the Indian data, we have 2 papers from India, one from Apollo Chennai. It's about 47 patients that has undergone this procedure, and the 3 year survival data is 76 patients. That means In 3 years, out of 100 people, 76% are still surviving. And this is a paper from Global Chennai, which is a 3-year data and reports a survival of 85 and 78 percentage at 1 month and 1 year. Another thing is the expense. So it is expensive. However, if it's done in a government hospital, is free of charge. There is a prolonged ICU stay and rehabilitations, and the public and private health insurance cover is minimum. So these are the challenges there. So in short, lung transplant is definitely an option for irreversible lung disease, and it's a part of a great teamwork, and government support is actively required for the smooth functioning of the program. And if somebody is having these kinds of problem of end-stage lung disease, which my next colleague will tell, it is advisable to refer early to a transplant center. Thank you.
Thank you, Dr. Burgess, for those inputs. And I think I stand corrected because I mentioned the first lung transplantation was in 1996, but you mentioned it's 1999. So our next panelist is Dr. T.V. Rajagopal, who's the consultant in interventional pulmonology at the Naruvi Hospitals, Vellore. With the objective to create an awareness about when to do transplants, his presentation is on indication for lung transplant. So over to you, Dr. Rajagopal.
Thank you. Thank you for your kind introduction. Okay. Dr. V, can you just stop sharing your screen? Yeah, sure. Is my screen visible now?
Yeah, it is.
Okay, let me start. So now we know that what is the status of lung transplant in India, and what do we need to do further? We need to know when it should be considered as a part of treatment. So we'll go about what is an advanced lung disease or an end-stage lung disease, because this is what is we are mostly dealing with when a lung transplant is being contemplated. And when should transplant be contemplated? Is it immediately after the diagnosis, or there are certain criteria to fulfill so that they go into lung transplant pathway? And what are the symptoms, the common symptoms of advanced lung disease? Though each specific disease will have a specific symptom, generally lung disease is considered to be advanced in case they have certain symptoms. Why is transplant indicated in advanced lung disease? Can we not just continue the medical management? That will be the question that will be lingering over everyone's mind. And a short list of diseases where commonly transplant is indicated. So coming to advanced lung disease, any lung disease that has advanced or worsened to the point where the patient is severely disabled or faces death from the disease in a very short period of time. If we don't do anything, the patient is ultimately going to succumb within a short period of time. That is what we call as an advanced lung disease or an end-stage lung disease. But mind you, the referral should be long before that. We shouldn't be waiting till the patient reaches the point of end-stage lung disease. We should be contemplating earlier, which I'll be subsequently dealing. And the second set of criteria which we should really think of is at least more than 50% risk of death due to the lung disease within 2 years if the lung is not getting transplanted. Next is they should be surviving at least 90 days after lung transplant. There are certain criteria to fulfill on that. I'm not going into the details of that. And they shouldn't be having any other general medical condition where their 5-year survival is, even though low, even when the lung gets transplanted, is one again criteria that needs to be fulfilled. So when should transplant be contemplated? It's a very complex process, and when possible should begin before the need becomes urgent, which means the patient shouldn't be waiting, or they shouldn't even think about transplant till they go into the end-stage lung disease, because it's a long process, as well as there'll be a waiting list for the donor lung to be harvested. And early referral may allow time for the candidates to address certain barriers to transplant, such as obesity, malnutrition, other comorbidities that needs to be optimally managed, inadequate social support, all this to be taken into account. So an early referral is the need before a lung transplant kicks off. Appropriate evaluation is a long process and even requires time to plan and execute. So a transplant should be contemplated in lung diseases which have the propensity to go into end stage after they reach the medical limits. So what are the common symptoms of an advanced lung disease? The patient is becoming breathless, having persistent breathlessness even on fully optimized medical management. the patient is having persistent requirement of oxygen, or patient is on ventilator even at home. Because of that advanced stage lung disease, the patient's exercise limitation is decreased, and they may even get confined to their own bed, and they are not able to fulfill their own day-to-day activities. Then reduced quality of life due to the lung disease. These are the commonest symptoms of an advanced lung disease. Why is transplant indicated in advanced disease? Don't we have any further medications to continue so that the patient gets improved back to their baseline? The problem is lung damage due to underlying disease makes it irreversible process. Unfortunately, lung is not as regenerating as a liver. Medical management has its limitations to improve the patient status, but they have their own limitations which we need to understand. We'll reach a point where all the medical management fails. And on top of it, a lung transplant gives a new life to the recipients so that they can lead a normal, productive life. So this is the list of diseases. We should be very careful. This is not an exhaustive list. These are the commonest diseases where lung transplant is playing an important role when it becomes an end-stage lung disease. COPD, as we all know, as chronic obstructive pulmonary disease, with smoking as its most important risk factor. ILD, where it is an interstitial lung disease, or commonly called as lung fibrosis. Pulmonary arterial hypertension. Cystic fibrosis, which starts from the pediatric age groups when they survive into adulthood, mostly require lung transplant. And bronchiectasis due to any other cause. This is a common list of diseases, but this is not an exhaustive list. So I am concluding my talk by just putting a note on, please pass it on, the gift of life which you have got. Thank you.
Thank you, Dr. Rajagopal. Our third speaker is Dr. Kumud Kumar Dhital. He's the Director of CTS and Heart and Lung Transplantation at QRG Merengu Hospital in Faridabad in Haryana, and a consultant at the Cauvery Hospitals in Chennai. And today he's going to talk about the surgical challenges in performing a lung transplant operation. Over to you, Dr. Dhital.
Good morning, everybody. I don't know if you can hear me clearly enough. Some of the features.
Yeah, we can.
You can. Wonderful.
Yeah.
So I'm going to take you through a little surgical journey and to speak about some of the challenges that are involved. We've already heard about how respiratory disease accounts for the second major cause of mortality in India, and where India ranks in terms of how bad this really is, where the global population is represented by 20%, but India has a burden of over 30% of the global lung diseases. If we just look at this world transplant numbers, all you have to concentrate on is that the number of transplants we're doing is less than 10% of what is required. The first lung transplant was actually carried out almost 65 years ago in a man, sadly, with cancer. But the point is that it was able to be performed, even though the gentleman died after 18 days. And those early stages, pioneering years, were littered with poor outcome, where between 63 and 78, only 38 various forms of lung transplants were carried out, with only one patient being discharged from hospital and only 9 surviving more than 2 weeks. And really, the Canadians in Toronto made enormous inroads. Despite that, however, by 1985, only 5 lung transplants had been performed. Now, of course, we're in the thousands, and this is in international numbers. All you have to do is look at the figures on the top right, capturing 80% or so of the worldwide numbers back in 2017. So now we're approaching more than 7,000 lung transplants, predominantly double lung transplants. Survival figures, I won't go into great detail, but you've just heard that the first-year survival is around 85%, around 3 years of about 70, 5 years of about 60, and about 40% at 10 years. And if you survive the first year, which is most critical because of the risk of infection rejection, you can add 5 to 10% to all those figures I have told you. How long will you stay in hospital? Typically, just look at the right column, you're spending in India and other non-North American European countries somewhere over that month almost. Whilst in countries like the US, patients are actively encouraged to be taking rehabilitation. They're referred very early on, which I'll come back to. And therefore, their discharge rates are a little bit quicker. And Europe, they're even higher because they also have the potential of staying in hospital longer for their rehabilitation. Now, what happens? Are you going to be hospitalized after your transplant? Well, these are very sobering and welcome figures, which is showing that almost 70, 80% of patients after their transplant actually are not being admitted to hospital for infection and rejection. And how good are you going to be? Well, even at 3 years after transplant, about 70% of patients are conducting a perfectly normal life, albeit about 40% of them with some minor symptoms. So how do we do this? One of the greatest challenges in surgery is to match the donor with the recipient. So beyond your blood group and the immunology and so on, it's a matter of the size of your chest cavity. That will differ between one pathology, one disease and another. And those diseases have just been explained to you. So the lung in the middle there will perfectly fit the cage, as you see on the left. It will rattle the one on the right. On the other hand, the lung that will fit to the right now is never going to fit on the left. And sometimes we have to take the risk by resecting, chopping some of that lung down to try and make it fit. And that is far riskier. And in some pathologies, we can just do a single lung transplant and make the normal size fit. And that is perfectly reasonable for patients who've been diagnosed with interstitial lung disease, which you've just heard about, because it is a non-infective cause. So in older patients who's getting sicker and awaiting a good bilateral double, and easily then have a single lung transplant with no difference in their prognosis or survival figures. How do we do that? We can do this via either two little openings on either side of the chest or across the chest. And this all depends on the nature of your disease, your body size, and your medical history. So these are just some pictures. I'm sorry if they're a little gory, but down here at the bottom, you will see this is a very fibrotic, this is lung fibrosis. And these are the various joins we have to do. We have to join the airway, we have to join the venous part, and we have to join the arterial part of the circulation to your new lung. And this is just showing you those attachments. Now, here's a beautiful donor lung on the left, which has just been transplanted. You'll see how lovely and pink it is on the left of that picture on your right, while the right side, you'll see the lung is still fibrotic, that has yet to be transplanted. And this is a fibrotic lung that has been removed from a gentleman who had these new lungs and who post-operatively has an X-ray looking like that on the left, at discharge in the middle, and at 3 months, you wouldn't even know that the gentleman had had anything done to them. And sometimes when everything fits and the donor organ is good, patient has been referred on time, and they're fairly well in terms of their muscle and strength, we can even do these operations through a minimal access with little openings on either side of the chest. So the numbers in India are small, we know, but they are increasing. There's a dip there because of COVID, but the numbers are increasing. Nevertheless, we're way short of what we really need to provide. And we've already gone through this, the terrible shortage of donor organs. So in India, there's less than one deceased donation per million population. Remember that for hearts and lungs, hearts, all of them have to be from deceased donation, but lungs, 99% really should be from deceased donation, and those numbers are very small. And so we need to expand our donor pool one way or another. And now we already have the tragedy of a huge number of deaths on the roads because of motor vehicle accidents, but not all of them are being converted into donors because they are the ideal donors. And then we have complications now that patients who are getting sicker are being bridged or being put on this expensive therapy called ECMO, which can sometimes recover your lungs, sometimes we can't do anything about it. And other times it bridges you safely to receive a lung transplant. And this is how complicated an intensive care unit can look with some of these patients. So we're increasing the rate of donation. We need to try and convert more donors from brain dead donation. And we're using what were thought to be riskier organs, but with excellent results. So we know that we're achieving good outcomes. So patients over the age of 55, I've transplanted lungs that are 70-year-old to patients, up to 74 years old, recipients. So we didn't used to transplant those before, and now we do. We take people who have smoked in the past, medical comorbidities, and so on. And there's another thing I want to briefly talk about, which is that legislation has still yet to be changed. But if we can utilize organs from patients who have died not because of brain death, but because of circulatory death, then the numbers would be increased by another 30% or so. I won't detail you with that, but circulatory death is when the brain isn't fully dead, but there's no chance of recovery. And the question is, how long would you leave somebody in a coma on a ventilator? And there's a decision made between family and doctors to remove the ventilator to see if there's any reflex to initiate a breath. And if there isn't, the patient, just like at home or somewhere, will die because the heart stops without oxygen and so on. In a controlled manner, we can do lungs and hearts from those donors. And they are now forming a huge component of the deceased donor transplants in the European countries and can give you excellent results. Is a series from Australia, 100% survival at 1 year and 93 at 3 years. And of course, there's an international registry now, which just shows you don't have to worry about the detail here. Just look at the slopes. They're identical slopes, whether the donor comes from a brain dead pathway or a circulatory death pathway. Now, what about more clever things we're doing in surgery? Well, lungs don't always come nice like the one on the left. Sometimes they come a little poorer. And sometimes bringing the organs back on ice is not sufficient, and we sometimes have to use machines to try and improve the condition of the lung. The two machines that are available now on your bottom right, I've had a lot of experience transplanting and lungs on the very bottom right, where you actually bring the lung back breathing. You can do the telescope, the bronchoscope to look at the lungs, and you can actually ventilate it. So you can actually have it breathing as you transport these lungs. Could we make these devices in India? Absolutely. We just need to be able to have philanthropic and corporate support to develop these projects and have them made fit for India at the local affordable prices so our patients can benefit from new technology. So machine perfusing and resuscitation of lungs is going to be here, and it will allow us to treat the lungs and even improve their response to immunotherapy, immunosuppression, which you have to take for lifelong after a transplant. And there's some other things that you may have heard about, something called xenotransplantation. Last year, a man received a heart from a modified pig and survived 60 days. But here, they're also experimenting now with lungs, and this has been done in animals. And soon enough, I'm sure we will be seeing this in the clinical arena. And the other ways of utilizing human lungs by taking most of the immunologically active cells away, leaving just the bare scaffold, if you will, and seeding it with stem cells and then transplantate. In similar way, there are lots of clever ways of trying to do this similarly from other mammals and hopefully to be utilized in man, and also to create lung tissue to actually try and give it the disease and test whether medications work on your sort of built up clump of lung cells, and then to try and develop that eventually into an organ itself. Now, coming towards the end, one of the most important things, of course, is that this is not a single thing. The surgical team and the medical team involved are vast. It requires a huge multidisciplinary effort to deliver something as complex as lung transplantation. But what can we achieve? If I was to give you those numbers there, which are the rate of lung transplants per million population in the UK, USA, and Australia. And if we emulated, let's say, in the UK numbers, we'd be doing over 3,000 lung transplants. If we did the 12 lung transplant per million population as Australia, we'd be doing over 16,000 lung transplants a year in India. So it is possible. And so, but the most important thing is a timely referral that's been referred to. Patients are being referred so late that they're no longer able to do the simple test called a 6-minute walk test, or do your lung function test, or the spirometry. And so they're arriving so late to try and get them operated and out of hospital in the 3 weeks, often in the package fees that are involved, is not impossible. So, and we haven't had a chance to develop trust between the transplant physicians and surgeons and the patient and their relatives to try and make them understand the changes in lifestyle after your transplant. So by far, the biggest surgical challenge has been the timely referral of patients. We'd rather see them early and send you back to your doctor and continue to see you once in a while than see you late. Because when you're referred very late over here, then you're okay. But if you then referred so late when you should have already had your surgery, we cannot guarantee that A, you will even stay on the list, or B, that you will get your transplant, and C, it'll end up sometimes becoming an assault on a body with no success, because the lungs by themselves don't do anything at all. They're passive balloons. So unless you have strength in your chest muscles, unless you have strength in your legs to be able to walk and actually utilize those lungs, they're of no use whatsoever, and they should be going to somebody who can benefit from them. So referrals are never too early, but are often too late. And when it's too late, we need to, as physicians and doctors, we need to be careful to say, stop, we're not going to do this, and because it would be, as I said, an assault on somebody's body. So we need to continue to augment deceased organ donation, which is happening in great strength in India across some states such as Gujarat, Haryana, Gujarat, Telangana, Karnataka, Maharashtra, and Tamil Nadu, principally. We need to standardize and make a fairer donation process. You heard earlier about the date of your registration, which gives you priority in India. Well, it would be far better to have the prioritization based on how ill you are. So at the moment, somebody who's quite well, but was registered a year ago, will take priority over somebody who might die within 2 weeks. And we need to keep a record of who's dying on our wait list. And we need to be transparent. We need to work as teams. And we need to utilize those patients who are dying from circulatory death, who are currently those often referred to as leave against medical advice. And we need to standardize all of our protocols. So what do I see by 2030? I see a donation rate of greater than 5 per million population, which in India would translate into thousands of transplants. I see lung transplant volumes exceeding 1,000 a year. I see R&D so that we're producing our own technologies here to help our patients with. That the state health does truly recognize that the donated organ is a national resource, and funding is a place to allocate that and transport that organ across states to another Indian recipient elsewhere, and that there is a transparent registry from which we can be telling everybody what we do. So a timely medical review and upward referral gives back life to the recipients, families, communities, and society. And this is a picture of a gentleman who transplanted over 2 years ago, who's just written in sending us a picture of how so good he is back at work in the job he loves doing as a policeman. So thank you very much for listening to me. These are some contact numbers and places that I'm involved with in various teams across India. Thank you.
Thank you, Dr. Deepal. That was quite an exhaustive talk packed with information. So now we'll move on to our last speaker, Dr. Robin Voss. He is an associate professor in the Department of Respiratory Medicine, Lung Transplant and Respiratory Intermediate Care Unit at the University Hospitals Leuven in Belgium. And in his presentation, he will now throw light on life after lung transplant. Welcome, Dr. Voss.
Thank you. Thank you for having me. And thank you for the invitation to give this talk. I'll try to put slides on. Can you see my slides, please?
Yes, yes.
Okay. So again, thank you for having me. And my talk will be about life after lung transplantation. And some of the speakers already alluded to life after lung transplantation. So I'm a academic lung transplant pulmonologist working for more than 10 years in a large academic lung transplant center in Belgium, close to Brussels in Leuven. And so this is closely tied to the university, which is one of the oldest universities in the world, actually. And so in this big hospital, we are doing a lot of lung transplantations. And this slide just gives you an overview of the numbers. And so actually, if you can compare it, we're doing in our hospital as many lung transplants a year as the entire India is doing for now. But I show this slide for a few reasons. There's one I want to point out here, that it takes time to build a program and to grow and to have sufficient experience to do these kinds of numbers of lung transplantations. And you see, we started our program in the early 90s, and it took us more than 10 years before we started to grow, because this first period was needed to build some experience. After we had an increase in our numbers, we're now at a phase of maintaining the number of transplants, and actually in this phase we are able to push the limits and have more complex patients transplanted. So you can see the numbers here. On average, we do about 65 to 70 transplants a year. In the entire Belgium, it's a small country, these numbers are around 100 a year, and one of the previous speakers already alluded that worldwide we're now doing more than 5,000 lung transplants a year. And with the increasing experience and the increasing number of patients being referred and transplants being performed, we now have performed more than 1,300 lung transplant procedures in our center. And so we have all of these patients in follow-up in our center. It's a small country, so patients don't need to come far for their checkup. And so we have about 677 patients alive and in follow-up currently, which is quite a lot of work to see these patients. Our survival is good, and this is something important to remember for the audience. We can have very good long-term survival after lung transplantation. This graph shows you the survival numbers of our center compared to the international registry. And I wish to point out that we're looking at a decade here, so 10 years after lung transplantation, more than 2/3 of patients are still alive in our center. And internationally, more than half of the patients will be alive. So you can imagine that if you get a patient referred for a lung transplantation, that you really have to think and plan for the long haul, and that you have to discuss with this patient that it will be for the rest of his life, for 10, 15 years or even longer, that there will be a need for medical follow-up after the lung transplantation. But this gives the patient a very good prospect of what he or she can still gain in life after transplant. In life years. Now, often patients, when they're referred, they ask you, can I do and live a normal life after lung transplantation? And there are some differences between what the patients hope for and what the doctors actually aim for. So the patients, they hope for performing the normal daily activities without too much respiratory symptoms, to be there for their family members, to maybe go back to work and school, to have some hobbies or do some sports, to travel, maybe to marry, maybe even to have children, altogether to live a long and prosperous life. However, the doctors, what we mainly aim for is to save life or to make the patient survive. And if once the patient survives his devastating respiratory disease, we aim to achieve and maintain a good functional capacity of both the lung and the patient. This is done by preventing rejection and infection. We also aim to have no undesired side effects, for instance, of the medication the patient needs to take, to avoid comorbidities, which are quite frequent, infection because of the immunosuppressives the patient needs to take, some renal problems because of the nephrotoxicity of the drugs, some cardiovascular problems, or even cancer can develop after transplantation. And of course, we want our patients also to perform daily activities. And it's not always easy to align these two different sides on what to expect of life after lung transplantation. Anyway, I think a lung transplantation is something that always needs to be proposed to a patient, and I'm not sure a patient can really ask for a lung transplantation. This is also something already alluded to by the previous speaker. So what we do really want is our patients to be referred in time to do the necessary diagnosis, the workup, and to put these patients on the waiting list, maybe even also to have the patients started on rehabilitation. And so here you can see the clinical status of the patients over time pre-transplant, and we don't want the patients to be referred too late, because then we cannot transplant these anymore. What we aim for after transplantation, of course, is to make the patient better or normal, better than his condition is when he's referred. But sometimes we do have to acknowledge that we're maybe not getting the patient better. And sometimes even if there are many problems or complications, we have to take into account that the patient may even be worse or even not survive the transplantation. And so to avoid all these problems and to get the best out of a lung transplant, really close medical follow-up, and this is lifelong, is really necessary. Because if you keep in mind that we are planning for 5, 10 or more years after transplant, you can imagine that a lot can happen during this period. And so we always aim to improve and maximize the patient and the graft's function towards a stable condition, but sometimes because of complications like infection or rejection, the patient is only able to function at the subnormal level, or even is rather medically unstable because of various complications, and this is of course reason for worrying. To try to avoid these problems and to really treat them as soon as possible, a close medical follow-up is necessary, and this is done in most centers and by a checkup of the patients every 3 to 4 months. And we at this moment do perform some medical tests, like testing the pulmonary function, some blood tests, chest X-rays, bronchoscopies, and of course, what also is pivotal is that the patient is taking his drugs, so medicine as he should, meaning this should be taken daily at fixed hours to prevent infection and prevent rejection. And in this way, I think many of the patients, if they adhere to this medical follow-up, can avoid problems and can really live a prosperous life. However, it all starts with dedicated teams and also dedicated family. You need the surgical team, the ICU team, and also the medical team to work together around a patient trying to achieve the best. But also the family needs to be in line with this, and also the family needs to be contributing to helping this patient to live a prosperous life. And so how to avoid these problems after lung transplantation then? Well, as already said, all the patients need to take lifelong immunosuppressive drugs, actually to suppress their immune system not to attack the lung. They need to be adherent to this treatment. They also are required to take other medicines to prevent infections, to be vaccinated, to take prophylactic or preventive antibiotics, antifungal drugs, antiviral drugs. Of course, it needs to be avoided to inhale a lot of toxins like air pollution and cigarette smoke, which may be a problem in India. So patients are requested not to smoke. And also some other drugs are needed to prevent side effects and to actually maintain a good medical status of the patient. With all this, I think we can say that patients can have a life-saving gift of life with lung transplantation. And there's one picture here. These are all patients of our being transplanted, and you can see they're living a happy life. There's one patient here with the red, with the yellow flowers and the red blues on the foreground and the dog. This is our patient who has been transplanted more than 30 years ago. She was the second lung transplant patient in our program, transplanted in 1991, and she's still living happily ever after. And I think this is something that we really need to aim for all of our patients. And so I do hope that in India, you can also achieve these excellent results over time. Thank you for your attention, and I'm happy to take any questions.
Thank you, Dr. Voss. And ending on that very positive note, and from his last slide, I would like to ask our doctors, who's the longest surviving lung transplant beneficiary in India? Like, what has been do you know? So you're not audible, sir. Dr. Deetal, you're not audible.
I don't know that number. I've only been in India now for just over a couple of years, but there are a couple of units certainly who have had a longer runway with excellent work going on, both in Sandy Batawal's team in Hyderabad and Dr. Balakrishna's team in Chennai, and with a few other teams now contributing greater volumes as well. But I'm sure we could ask our colleagues and find out.
Right. Dr. Verghese, you wanted to say something.
Yeah, that data we are not very clear on that now.
Okay, no issues. From all your presentations, of course, one does understand that lung transplant scenario still is little complicated. But I have one very basic question or doubt in my mind. You know, when we talk about the other streams, we talk about, say, cornea transplant, or we talk about even perhaps heart transplant, where the numbers are definitely much higher. And that is also coming from organ donation. So what is the reason that lung transplant is not really catching up? Because there is also a feeling that organ donations are kind of increasing in the country, and when we are kind of harvesting the other organs, then why not lungs? Why is that not happening yet?
Well, the lung, if I can answer this quickly, the lung is a bit more complex organ in that it is open to air. It is much more susceptible to issues of the healing of its various joints we have to make. And so patients who are on heavy steroids, for example, can have issues, as they did, and was the cause of mortality way back in the early historical days. But the main problem is that it is still not well understood in the community and even amongst our physicians of the when to refer these patients when they can best benefit from lung transplantation. The numbers are increasing, but it requires a much greater team and much more complex perioperative and postoperative course to keep these patients alive. And as I mentioned earlier in my talk, matching lungs from between the donor and the recipient is far more complex than certainly for kidneys and livers, where it doesn't matter what size, let's say 60 kilo can go into an 80 kilo a person. For hearts, for example, it's about engine size. You can't put the engine of a Maruti in a Fortuner. Of the lungs, it's about the size of the cage that you have. That'll vary with the disease you have and your height. And so it means that we often may have recipients on the list and have a donor we cannot utilize. Or if we do and we have to chop the lungs, we increase the risk of the surgery. And if the patient's already been referred late and very, very poorly, they're likely to then end up with a very poor outcome. So all these factors that go into making and choosing and selecting the donor for an appropriate recipient is far more complex than for lungs. And finally, there are very few people who have been trained and are experienced in actually performing and looking after these patients. India has very few formally trained surgeons or transplant pulmonologists who are providing this crucially required service, not to get the patient out of hospital. That's not a success. But what Dr. Voss has been going on about is really the medium to long-term survival of these patients. That's the end goal. It's survivorship. And survivorship is the success. The discharge is not, because the patient needs to survive longer than they would have survived had we not operated on them for there to be a success in the first place. So for ILD, that can happen at the time of a discharge, but for COPD, it may require months for the patient to be alive before they benefited from transplantation.
Right. And what is the period you can keep the lungs, harvested lungs? Is there any timeline to that?
Yes, there is. As we know, livers and hearts are much more susceptible. This period called ischemia, where no blood is flowing through the organ. So for hearts, we like that to be not much more than 4 hours. Lungs, we can go up to 8 hours, sometimes more, but ideally, we'd like to keep that below 8 hours, around 6 hours at most. And the shorter, the better, clearly. But they're a bit more resilient than hearts and livers.
I would like one of you to focus a little bit on the cost of lung transplant. That could also be another deterrent in lung transplants, happening more in the country. Who would like to take it? Dr. Varghese, Dr. Raju? Yeah.
So right now in lung transplant, the cost is a little concern. So usually when a patient is being listed, we usually tell the patient to get the sick insurance and private insurance, which will support to at least few lakhs in their total expense. However, roughly we usually tell a patient to at least arrange at least 20 to 30 lakhs minimum. It depends on how long your stays in the hospital, etc. However, once a patient is being listed, we tell them to arrange roughly this amount, and we usually tell them to get the insurance schemes and the different NGOs or different organizations to help in this aspect, which contributes a lot in the total expensive journey. However, it's a life-saving procedure, and it is like how Dr. Voss was saying, it is like giving a second life and making a patient live for at least more than 20 years. It's a gift which is it's totally different, I think, which we can say.
So what I also understand from the presentations, especially in India, like the facility available is very metrocentric. I mean, you have just named a few cities where lung transplant is done. So what about the people who are in deep interiors, who are in states like Bihar and Madhya Pradesh, and what is the way out or way forward for them? How do they approach and how do they decide and choose?
So
all of you could give your inputs, because it's a general question.
So usually, for most of the hospitals, they conduct a peripheral lung transplant outpatient clinics in the different rural areas, which is being conducted weekly once or monthly once, etc. Where we have a talk with the local physicians, and we make sure that they are able to pool the patients on that specified date and time, and we see the patients, and we usually address the issues of transplant and what is the life you should hope for. And usually we either do some of the few tests that is required transplant in that nearby hospital or in the main center. That is one way, it is basically after this awareness, patient approach the hospital or the main transplant center, which will make the life more helpful. However, the peripheral lung outpatient clinics are being actively done in India, so that the rural areas are also covered upon.
Dr. Didal, is there a suitable age group for performing lung transplant?
No, any age, as I mentioned to you, there are institutional age criteria and limits being set, but internationally, age limits now have been pretty much removed, because it's really a question of what your body is like physiologically. And so, I've transplanted up to the age of 74, but they have to be good. When you look at them and they see how fit they are, they're like your average, 60-odd-year-old. So age is not per se the criteria. Of course, the older you get, the risks can be higher, but no, it isn't. And sometimes even children need lung transplantations, but thankfully those are rather rare.
Mm-hmm. Dr. Rajagopal, how long does the pre-operative work take before a surgery is decided to be done?
It depends on the each specific diseases, ma'am. First of all, the baseline patient status needs to be assessed. Then after that, the workup starts, and how emergent is the lung transplant required. All this put together, we cannot give a single timeline for a lung transplant, but it depends on specific diseases. Certain conditions, like patient will be on life supports, then it's an emergent condition where the workup has to be shortened based on the patient's criteria. There's no single answer for this, but usually early referrals, why we are stressing is we cannot, certain factors cannot be modified, like the patient's emergency condition. A patient who has been stable on a lung oxygen support suddenly starts deteriorating. If the patient has not been worked up for a lung transplant, then there's no point in pushing harder when the patient is on life supports. So there's no single answer, but earlier the better is what everyone here would agree to.
So when sorry
to interject, the standard time for somebody, without those complications that have just been mentioned, is somewhere, depends on the institution, but it's between 3 and 5 days of in-hospital, where you get top-to-toe investigations done to look at every single organ, including assessments by dietitians, psychologists, and other multidisciplinary colleagues, as a whole, to make sure that you are a good candidate and you do have that chance of the survival at 5 years of 80% and so on, undergoing the lung transplant. So 3 to 5 days, standard.
Right. No, then if the cost of a transplant is average, say 30 lakhs, then there is also the post-operative maintenance of a patient. So how does one deal with that?
Well, 2 issues. One is to add to the lung transplant costs is the workup cost. That again varies between 2 to 4, depending on your institution and investigations being done. That's separate to the transplant cost, which often is a package over a certain period of time. And that if you're referred late and you have other comorbidities, other medical conditions that make you at risk, then you're likely to stay in hospital longer. And of course, the costs will go up. Post-operatively, it's not the end. So when you're discharged, as Dr. Voss so eloquently explained, the need for surveillance and regular follow-up at the transplant center. Patients will continue to have that transplant center at zero threshold to call and go in for any medical issues, because we're concerned that we do not miss episodes of rejection. So the first year is the most expensive in respect of biopsies and other more rigorous surveillance, but that together can cost anywhere between 3 and 5 for the first year. Thereafter, the costs go down significantly into 15,000-20,000 a month, perhaps for your medications, particularly if you're not on any antibiotics at that point.
Mm-hmm. Dr. Voss, like after any surgery, people are normally worried about their productive life. So how do you assure patients? How do you go about it?
So I think, as I mentioned, I think many people, if they, let's say, want to go back to work, and also show my Dr. Marital, it's possible, depending on the work they do. If people ask me, well, I want to become a father or a mother after transplantation, this is a bit more complicated. I mean, there are some side effects of the medicine they need to take. And actually, like for pregnancy or becoming a mother, this is something that is really, let's say, not advisable. We only have in our center 3 patients who ever became pregnant after transplantation, because it's such a complex issue immunologically and also with the medication. So this is something that's not really preferable, but it is possible with the current state of the knowledge on immunology and the treatments. It is possible, but it's actually for a very well selected and very limited number of patients.
I'll quickly take a few questions. Some of them sound a little technical also. So Mr. Hari Manikum is asking, what about the transplant surgical intervention in a viral serology positive patient?
So, so usually, ma'am, the viral serology positive, it can be because of different virus, especially if the question is addressed for human immunodeficiency virus. It is possible, but we make sure that the patient's viral load is very low, and we make sure that there is no prefix antibodies that is having. However, it is possible, but it has to be greatly dealt upon with the pre-transplant screening for multiple other issues, so that we can make sure that he is the right candidate whom we can do transplant, but it is possible.
So Pushpa Gaikwad wants to know, would you consider lung transplant if a patient also has cardiac/renal failure?
Okay, so there are conditions where we have to do a combined heart and lung transplant. That is typically for 2 conditions. One, which is congenital heart disease, which then affects the lungs, and therefore both organs fail and you need a transplant. The other one is when you've got something called pulmonary hypertension, which has then affected the right side of the heart to make it fail, so that it's little chance of it recovering, and then you might need to do a combined heart-lung transplant. Those are the typical reasons for doing it. What was the second part of your question?
No, and also, what is the difference between the single lung and double lung transplant?
Okay, yes. So conditions that are infective, or we call suppurative, such as bronchiectasis or cystic fibrosis, of which there are much fewer patients in India than in Europe, require bilateral lung transplantation. This is mandatory. For patients with ILD, as has been explained, or certain types of COPD, you can get away with a single lung transplant, particularly if the patient's deteriorating and organs are not readily available. Or, as I mentioned, in the ILD group, the patient who's over the age of 60, 65, for them, a single lung transplant is perfectly reasonable, even on a prognostic basis, to try and get a timely transplant carried out. So, and then there may be other conditions that necessitate you being only able to do a single lung transplant. but those are very individual and tailored to the patient's specific requirements. But yes, so in terms of lung transplantation, single lung transplantation, double lung transplantation, heart lung transplantation as a block, and when you're thinking of children, and groups in Japan are doing lobar transplantation, and even from a living, so parents donating one lobe each to their child. But the results in the medium to long term aren't as that great, but there are only really a couple of units in Japan doing this sort of work.
Right. So somebody's also asking about the waiting period for getting a lung transplant done, whether it is single or double or any average waiting period.
So it depends
Well,
upon
go ahead.
Yes, it depends upon the state which you are enrolled in. So many states like Tamil Nadu or Hyderabad, where the donation is more, so the usual preference will go to the people who is living in that state. So roughly we can tell that it is at least between 3 to 6 months. So we usually, once a patient is being listed for a transplant, so we usually tell them to stay somewhere near the transplantation center. So when a call is being obtained, this process will be early.
Since we have all lived through COVID times, Dr. John Sarkar is asking that has any lung transplant taken place solely due to infection from viruses of COVID-19?
Yeah,
Yes.
maybe I can answer also.
Yeah, please.
Maybe the European American experience first. Then, so our center, we have transplanted only 3 patients due to COVID-related ARDS, which is actually kind of end-stage lung failure due to the infection. So we did 3 patients. The largest experience in Europe is in Vienna. They did about 40 patients. And in the United States, I think more than 150 patients by now have been transplanted due to COVID-related lung failure. So it is possible, but it's still a limited number of patients that we transplant for this condition, because there are, of course, many other patients waiting on the waiting list with COPD, with lung fibrosis and things like that, who also need the transplant.
And India has a great experience in having done just that, with patients often being bridged to a lung transplant post-COVID with ECMO therapy.
But in India, why is lung transplant largely or maybe only with the private sector? Does the government have any kind of facility available?
On the whole, and I'm speaking for probably 95% or more of the cases, are done in the corporate sector. You're absolutely right. The team, the necessary team and expertise required, the intensive care environment required, almost therefore mean that it is likely to be in the corporate world. I mean, it's a tragedy, to be honest, because for me, who's worked in the UK and Australia, where it is free at the point of care, the fact that your average person is excluded by virtue of this, size of their wallet, is very depressing to me, because there's no standardized way of funding this. Some states have a CM fund, others don't. And often even that is insufficient to cover the cost, particularly when the patients are referred very late. So we do need to have some wider discussions around how we're going to fund the very patients whose communities are the ones that are probably donating most of the organs. So we've got to redress this as a nation and individual states, whereby health obviously is delegated to them. But there is a huge disparity in almost a postcode disparity of availability of funds. But having said that, if we can get a timely referral, we can have recourse to crowdfunding and other philanthropic charity support that is very present in India, this sort of altruistic donations that we can leverage if only we have time to be with the patient and have them referred early on.
So when you're reiterating the fact that there is a delay in timely referral, it is also kind of accusing your own fraternity. What exactly is the problem or the reason? Is there a lack of enough doctors or pulmonologists or pulmonary surgeons, or there is lack of total awareness that could you just elaborate or explain that part? Because this
A little
timely
bit of all.
referral thing has been
A little bit of
yeah.
everything you've mentioned. So you can't just do these procedures because you feel like doing it the next day and you happen to be a lung or a heart surgeon or a pulmonologist. It takes very rigorous training in a formal setting. You don't get that expertise by doing a course for 3 days or a week or 3 weeks. You really need to be immersed in a program like Dr. Voss's program or some big volume centers where you're there for a fellowship or a significant period to learn the intricacies of how to keep these patients alive after surgery. And similarly, surgery itself is a very personal thing for those individual patients. There'll be a lot of complex anatomical issues, previous disease, stuck lungs, that all make it very complicated. And if you've not had the training formally in doing that, it's a bit cavalier to just start off on your own back. And just to give you an idea, they're in the 90s. So there are almost 100, I should say, authorized heart and similarly lung transplant centers in India, but they're less than a handful actually doing any sensible volume of work. So you have to question why that is.
Okay, I think some people also want to know which are the hospitals doing the lung transplant in India or South India or wherever. So if one of you could answer that question instead of
there's several.
out.
There's those who've been very well established, as I mentioned earlier, the KIMS Hospital in Hyderabad, the MGM in Chennai, and there's the places where I work, which is across. Now we're developing a center in Haryana in Faridabad with Marengo, which has a branch in Ahmedabad where I go and transplant there. The Kaveri is another hospital in Chennai, and the Apollo Group in Bangalore. And there is also Medanta in Haryana and Delhi NCR that has recently started. And then there is smattering of the odd lung transplant being done here and there. So those are really the principal places. I think patients should have a survey what's available, find out the experience of the teams. It's not just a single person. They need to find out what the experience of the overall team is before they make that decision.
Dr. Rajagopal, there's this question for you that if I have COPD and I'm started on oxygen, I was started on oxygen last month, is there any timeline or oxygen levels to wait for listing?
No, there is no oxygen limits or something. Like if
Okay.
he had a flare-up of his symptoms last month and he's recovering from it, then he may be even off oxygen in next month. It doesn't mean that the patient has reached the end stage. It has to be properly evaluated to see whether the patient's like medical management has reached its limit or not. So it doesn't mean that the patient was started on oxygen, immediately transplant has to be contemplated. It has to be taken with ideally the advice would be to go and meet the pulmonologist and the transplant pulmonologist, sit together with the discussion and find out what the disease status is. Then it can be decided upon.
Like these annual medical checkups are kind of building up and people do go for various tests. So would you recommend that people should, is it necessary after certain ailments or after certain age that people should, because I think one of you mentioned about the 6-minute test, which people kind of forget to do. So could you just a little bit once again speak about that?
I think it's crucial. And this is not being done properly. Majority of patients, even in the pulmonology clinics, are not getting their full lung function and 6-minute walk tests. So when they do arrive very late, actually unable to perform those tests, we don't have an indication of the trend of how they've been deteriorating. And to have, as you've suggested, at your workplace, from your doctor, those simple tests, if you have got some respiratory disease as a baseline, is absolutely crucial, because that allows you to get a trend of how you're deteriorating and then be referred on at an appropriate time. And seeing a transplant pulmonologist, I think what we should say is seeing a pulmonologist whose expertise is in advanced lung failure, and that of course includes transplantation, it doesn't mean that you necessarily need a transplantation. It is to get a rubber stamp, if you will, from an expert who just deals with that, who can then say, you know what, it's a bit too early. Why don't you go back to doctor? Let's see you in 3 months or 6 months. But to have someone who comes so late to say, I'm so sorry, if you're either too late, or if I don't transplant you in the next 3 to 6 months, you're going to die. Being on the wait list does not guarantee you a transplant, because if you continue to deteriorate, we will have to pull you off the wait list.
Right. So that was the little bit of the fear factor I was wondering, because people may not be very confident. They may feel that the survivability rate after a lung transplant is not really, doesn't really increase your lifespan by so much vis-a-vis the amount of money you are spending. I mean, it sounds a little moronic, but that is a fact. So do you think that also plays into account for less transplants?
Undoubtedly. If you see, Dr. Voss presented lovely data that he can explain to his patients. Unfortunately, in India, we don't even have a proper registry. We don't know what's happening. Not everybody is talking about their transplant outcomes and so on. So we don't have the community knowing what's going on. We don't have physicians knowing what's happening. And if they knew that, and we had more surviving ambassadors in the communities, they would themselves drive and referral patterns. I don't believe that it's the community fault for not donating. I think it's our fault as physicians for not being transparent enough, to therefore encourage communities to donate, because they can see the benefit within their own local areas and amongst their friends and families.
Right. So I think we have already overshot our time limit, and I would like to wind it up at this stage. Would anybody like to give any last round of inputs or summarize anything for a quick reiteration of emphasizing on awareness or something?
So one last point is, as you know, the lung transplant is a life-saving surgery. And being a large country like India, where more donation is required, I hope the general public understand the importance of donation of the organs, and only after donating the organs we can give life-saving treatment for those suffering from end-stage lung disease. So please make sure that you use all the opportunity or the hospital which the doctors have mentioned if you have any end-stage lung disease, so that proper treatment and proper planning of the surgery can be done. In case of any queries, you can contact any one of them through the phone number or mail ID, etc.
Right. So thank you very much for joining us for this all important session and being part of this webinar brought to you by Naruvi Hospitals and the Hindu Wellness Series. Thank you all once again.
Thank you. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.